Okay, today we are talking about mental health. So this should make sense, right? It's a psychology class. We often talk about, sometimes when I see clients, we often talk about mental health. Mental health can mean so many things. But today we're going to talk about medication or drugs specifically for mental disorders. Okay. So when we talk about mental disorders, we use the medical model. Now, a lot of people have issues with this. However, it's the way that it is right now. So, interestingly, we look at the symptoms of what's going on. We then come up with a diagnosis. Okay, so for example, someone is lying in bed, not really hungry, feeling hopeless, not interested in a lot of things. We're going to give them a diagnosis of major depressive disorder. Then after that, we're going to look for the causes of this disorder. Is it due to a difficult childhood? Is it due to a imbalance of serotonin and norepinephrine in the brain? Is it due to blah, blah, blah? Okay. And then we look at a treatment. Okay. Should we look at using an antidepressant? Should we look at using cognitive behavioral therapy? Maybe something in combination. And then we talk about a cure. I'm not a big fan of the word cure, but as mental health issues are often things that come and go, things that are always, to me, on a spectrum. The other part of the medical model is really that you are either in or you're out. You have it or you don't. You have major depressive disorder or you don't meet criteria for it and you technically don't have a diagnosis of it. I don't love that because I feel like, well, I think most things are on a spectrum. Mental health being one of those things that are on a spectrum. And that would be, some people are really very horribly depressed and suicidal. Other people are intensely happy. And most of us are somewhere in between. Most of us have days where we feel that sort of kind of cloudy brain. It's more difficult to walk. It's more difficult to think. But it's transient, and maybe something happens and the sun comes out later and we're feeling great. For other people, they stay cloudy. For other people, they have no idea what that even means because they've never experienced that. So other criticisms of this model. Usually, the only symptoms of mental disorders are behavioral. We don't have a blood test that says, yes, you have depression. They're behavioral symptoms. They are self-reported symptoms, which means people have to be aware enough of themselves to be able to say, this is going on with me. Also, behaviors are really varied, and they can have so many causes. So many different things can cause the same disorder. So, the models guides a lot of our current thinking, though. That is the medical model. And so psychoactive drugs are used to control symptoms of mental illness. Researchers continue to identify chemical imbalances associated with specific mental disorders. And we say chemical imbalance, and what we mean by chemical imbalance is maybe somebody has, quote, too much dopamine or not enough dopamine. And when we say too much or not enough, what we mean is, if you think about, let's go with dopamine. If you think about the neurotransmitter dopamine being transferred from, going back to one of our beginning chapters here, from the presynaptic neuron into the synapse, that little space in between, and then going to the postsynaptic neuron, there's time when it is in that synapse. And sometimes it stays too long. And sometimes it doesn't stay long enough. And sometimes too much of it is sucked back up into the presynaptic neuron and not enough of it goes to the postsynaptic neuron. Or sometimes it goes too much. And so chemical imbalance basically means something is going awry when a neurotransmitter is being moved from one neuron to the next neuron, okay? And so by chemical, we mean neurotransmitter. By imbalance, we mean something's a little bit off about it, okay? Different neurotransmitters are associated with different mental health disorders. Now here's a picture of our DSM-5. This is the most current, the most updated diagnostic and statistical manual of mental disorders. Ta-da! It's purple. Of course, you've seen a picture of our silver book before, and that's the one that, I was trained, of course, on the DSM-4. The DSM-5 has made a good number of changes, not actually as many as people had anticipated, but it has made some changes. There are a lot of controversies over this. Just a plug, I also teach an online abnormal psychology course here at UAB, and we go through the DSM and we go through all the different disorders, and we really talk about some of the potential issues with the current new DSM-5. Some people have decided not to use it, which is kind of interesting. Okay, that's a whole, I could do a whole lecture on this, so I'm going to move on. So again, here's our DSM. It's going to give us the classification system for, hundreds of disorders. Let's start with anxiety disorders. Now, we just talked in our last chapter about benzodiazepines and our different medications that are used for anxiety disorders. Let's talk about what are our potential anxiety disorders. These are characterized by excessive worry, excessive fear, excessive avoidance. Things like specific phobias. That's like, I'm afraid of heights. I have a phobia of snakes. And a phobia would mean that it's so excessive that it's stopping you from doing what you need to do. Okay, if it's just I don't like it or I'm afraid of it, then it's not technically a phobia. If it's excessive to the point where you're not functioning well, then it's a phobia. Okay, social anxiety disorder would be where you don't like being around other people, you really feel uncomfortable speaking in front of others, you fear scrutiny from others. Panic disorder would be having panic attacks and then having a general fear of having a panic attack. Agoraphobia is the fear of being around other people to the point where you're just going to stay home. It's not just about the scrutiny of others, it's really about feeling intense panic symptoms around other people. Then we have our generalized anxiety disorder, and this is where it's not specific like the other things. With the others, we know what triggers it. With generalized anxiety disorder, it's being around other people makes me anxious, being by myself makes me anxious. I'm anxious in the morning, I'm anxious in the evening. Pretty much anxious all the time. Okay. I love seeing people for anxiety disorders because we have well-researched cognitive behavioral treatments that work well for people with anxiety disorders. Now, psychosis. Moving on here. Psychosis is a serious mental disorder involving a loss of contact with reality. Okay? Schizophrenia is often the diagnosis that we talk about when we're referring to psychosis. This chapter is a general overview. Take my other class if you want more. But when we're talking about schizophrenia, we're going to look for delusions. Delusions are thoughts that are wrong, basically. So a delusion would be, I think I'm the king of England. I believe that I am Jesus. I believe that people are listening to my thoughts. Hallucinations are going to be, I hear voices. I see things. I feel things that aren't there. I taste things that aren't there. Disorganized speech is when somebody kind of talks in a, maybe you've walked by someone who appears to be talking to themselves, but in kind of a nonsense way. Disorganized behavior would be sort of looking disheveled, maybe wearing several coats on a hot day, things like that. And then lack of emotional response. would be when you talk to somebody and they have the same sort of monotone response and look for no matter what you're telling them. You can tell them your dog died, you can tell them you won the lottery, and they have the same thought, the same sort of mannerisms. Schizophrenia causes significant interference with social or work functioning, family functioning. There are good medications, not perfect, but good. However, a lot of times people don't take their medications, they don't like the side effects, they don't remember to take them, and that can be a problem. Okay, mood disorders. So within the mood disorder spectrums, we have major depressive disorders and we have bipolar disorders. With bipolar 1, for example, you're going to have at least one manic episode. Someone who's going through a manic episode is thinking really fast and they're talking really fast and they're thinking about doing this and they might end up going out and spending all their money, maybe sleeping with people, just doing whatever they want to do. Okay, manic. And then also often having depressive phases. So those are our mood symptoms. And like I said, people don't always fit neatly into a diagnostic category. They may at times fit something and at times fit other things. Okay, early treatment of mental disorders. So syphilis, you do want to know this. This general paresis. So people had syphilis. The syphilitic infection of the nervous system causes people to experience psychosis. Okay? The reason that we care about this is that a medical condition, syphilis, you can know that they have it and you can see mental issues occurring. So it was one of the first times that people said, oh my gosh, maybe psychosis is not just caused by having a cold, disengaged mother, but maybe psychosis is caused by the brain and something going wrong in the brain. And then maybe other mental health disorders are also caused by the brain. Ta-da! Okay. Interestingly, with malaria therapy, the fever associated with malaria was thought to improve the condition. However, later antibiotics were developed and that cured syphilis. And when the syphilis was cured, the psychosis went away. All right, early pharmacotherapy. We had narcosis therapy. This is depressants were used to induce sleep for a week or more. The idea was if you just knock people out, they are no longer a problem. We had our truth serum that was used during psychotherapy, and the idea was it would help people talk and express these repressed thoughts and repressed feelings. To be clear, we don't do these things anymore, okay? We had insulin shock therapy, and that was used to treat schizophrenia. And I want to be really clear, insulin shock therapy and electroconvulsive therapy do not work for treating schizophrenia. They were used for that, but it does not work. However, electroconvulsive therapy is currently used to treat depression that hasn't been able to be treated in other ways. So that is that if somebody has not responded to medication, anything for a long time, they do electroconvulsive therapy. Okay, what is that? Basically, you're inducing a seizure into the person's brain. What they find is when somebody experiences a seizure, afterward there's a period of euphoria. We don't know why this works, but for some people it works and it works well. For some people it doesn't work very well. But basically, if you're in a place where you want to die every day, going and trying something like this is worth your time, because maybe you won't want to die every day. And like I said, for some people it works well. Again, this is something, if you're interested in, read more about it online, in your book, take another class on it. Okay. Antipsychotics. So we have our phenothiazines. These are an early group of drugs used to treat psychosis, reduce psychotic symptoms without sedation, not just knocking people out. Initially, these were called tranquilizers or neuroleptics, and now they're called antipsychotics. Okay. Following the introduction of drug therapy, all of a sudden restraints, convulsive therapies were reduced or completely discontinued in psychiatric hospitals. Now that we had drugs to help people outside of the hospital, they didn't have to be confined or institutionalized all the time. Huge difference. Okay, then we have something called our atypical antipsychotics. The mechanism of action is going to be different from the phenothiazines. All recent antipsychotics are technically atypical antipsychotics. Okay. Now, the mechanism of action. These are dopamine antagonists. So they block the D2 receptors. One issue is that they can, in too high of doses, these are our typical antipsychotics, typical, produce what we call pseudo-Parkinsonianism. Do know this word. So pseudo-Parkinsonianism refers to Parkinson's disease. So when people have Parkinson's disease, they have rigid muscle movements. They do something with their tongue that's called lip smacking or pill rolling, also referred to as tardive dyskinesia. That's something you may want to look up online if you want to see sort of what that looks like. But again, what happens is because schizophrenia and Parkinson's disease seem to be on the opposite ends of dopamine, if it's too much or too little, the antipsychotic medications at too high of doses will cause pseudo-Parkinsonianism. Interestingly, people with Parkinson's disease, if their medications are too high, they actually start to exhibit schizophrenic-like symptoms. Okay, so this is how you know your medication is too high, is if you start experiencing things on the opposite end. Now, a time delay in drug effects indicates that the mechanism of action is probably more complex. This is true for most mental health medications, and that is that there's a time delay. So you take the medication one day, and then you take it every day, and it starts to work maybe 2 weeks later, which means that we can say we think that it does this to the brain, but the truth is it probably does something that 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 does this to the brain, making it more complex than we understand. Now, our atypical antipsychotics are serotonin and dopamine antagonists. They block both the D2 and the 5-HT2A, which is serotonin. If you ever see that 5-HT2A, you know that we're talking about serotonin related to mental health issues, those receptors. And they produce less pseudo-Parkinsonianism. You still want to watch it. Okay. Antipsychotics, they're generally safe. They don't produce drug dependence. It's really difficult to kill yourself with it. Now, there are side effects that people don't care for. Some allergic reactions, photosensitivity, meaning you need to wear sunscreen if you're going outside, low white blood cell count, you need to be followed by a physician, that pseudo-Parkinsonianism, and then this last thing is what I just mentioned. I would recommend, looking up maybe, a video of what tardive dyskinesia looks like. I think it's interesting. It's the most serious complication of the drug treatment. And the problem with tardive dyskinesia is that once it begins, sometimes you can't get rid of it. So even if you stop the medications, for some people, this stops. For other people, this is now a permanent muscle reaction. I don't know if muscle is quite the right word, but it's physical. It's a physical thing that's happening. It's not a mental thing that's happening. Okay. Long-term effectiveness appears to be considerably lower than short-term. So 75% of patients discontinue by 18 months. No clear evidence that atypical antipsychotics actually work better than conventional. In special populations, children are at high risk of weight gain and metabolic changes. The elderly are at significant increase in death risk from cardiovascular and other problems. So again, these medications are not perfect yet. All right, moving on to our antidepressants. Within our antidepressants, we have our MAOIs, our tricyclics, and our SSRIs. And now we also have our SNRIs, but we'll get there. Okay, so our MAOIs, these are, well, it was a tuberculosis drug, and they noticed that it also elevated mood. It increases the availability of serotonin, norepinephrine, and dopamine in the synapse by actually inhibiting the enzymatic breakdown. Now, it's limited use of side effects and toxicity. Limited use due to side effects and toxicity. Some people still take MAOIs, and if you've ever heard almost any medication commercial on TV, they often say if you're using an MAOI or have used an MAOI in the past 6 months, please don't use this medication. MAOIs are not good in combination with most things. They also have issues like hypertension and what they call the cheese reaction. You may want to look this up, but generally there are a lot of different foods, They say cheese because aged cheeses are one of the things on the list that you cannot consume if using this medication. So very few people still take it because it's just a difficult medication to use. Now, our tricyclic antidepressants are still used for people, not that popular anymore. And actually, tricyclic antidepressants are often now used for things like chronic pain issues like fibromyalgia, interestingly. So they were looking for a better phenothiazine antipsychotic, and they actually resulted in coming up with these drugs that elevated mood. They increase the availability of serotonin, norepinephrine, and dopamine in the synapse, but they do it by interfering with the reuptake of the drug. Okay? Not effective in all patients, but like I said, some people it works well for, and they reduce the severity and duration of the depressive episodes. Now, are more popular now. Our SSRIs. SSRIs are probably the ones you've heard of. These are our Prozac, Zoloft, that crew. Now, also more popular are our SSNRIs. Some people call them SNRIs and leave out that extra S. And these are our selective serotonin and norepinephrine reuptake inhibitors. They're going to increase the availability of serotonin and or norepinephrine in the synapse by interfering with the reuptake. Okay? They're safer than the tricyclic antidepressants, less likely to lead to overdose deaths. There is a warning about increased risk of suicidal tendencies in children and in adolescents. So, you do want to be careful that these medications are not actually increasing thoughts. It doesn't happen often, but you do want to watch for it. Trying to think if there's anything else I want to say about these. I think that's generally it. Okay. Now, electroconvulsive therapy, which I already mentioned before. It's mostly effective for severe depression. It's the best choice in cases with risk of suicide because you're not giving them medication. It can be used in conjunction with drugs. If you ever have a chance to go and watch ECT being done, I'd highly recommend it. If you look at old ECT videos, if you've had like a Psych 101 course where they showed you old videos, it's horrible. It's absolutely horrible to watch. Currently, when ECT is done, people are brought into the hospital and they are given medication so that they are out. And when ECT is done, the body doesn't move. The only thing that you see is maybe the toes move up and down a little bit. So you can know that something's happening in the body, but nothing, you're not being harmed like they did in the past. Okay, now here's the thing. With our SSRIs, SSNRIs, well, you're going to have to wait probably about 2 weeks for the medication to start working. When we have people that are intense suicide risk now, waiting 2 weeks is not acceptable. And so ECT is going to relieve the symptoms now. There are side effects, right? So some people complain of memory loss. ECT, I don't think, is the perfect solution. Interestingly, and this goes along with one of your discussion questions that I've given you, or will be giving you, I don't know when you're watching this video, and that is about ketamine. Our book doesn't really focus too intensely on some of the alternative drugs that are being explored, but ketamine, for example, is actually, there are drug trials going on here at UAB with giving people who are intensely depressed a dose of ketamine. Look it up. It's one of your discussion questions. You'll learn more about it. I don't want to give everything away. And the people are having immediate relief from depression. Now, there are some questions as to how long that will last. There are some questions about its longer-term effectiveness. There are questions, of course, about side effects. We don't know everything yet. However, and I say ketamine one more time, but there are also lots of other drugs, medications, plant medicines, whatever you want to call them, that are being explored for mental health issues. So MDMA, which is ecstasy, is being explored for things specifically like post-traumatic stress disorder and having some pretty good outcomes. Psilocybin, which is magic mushrooms, is being explored for things like addiction issues, whether it's smoking or cocaine or whatever kind of addiction issues. I just talked to somebody who was talking about wanting to look into psilocybin for actually treatment-resistant depression. So we will see where these things go. I'm not an advocate or someone who's saying don't I'm not picking up some sort of thing where I say everybody has to use hallucinogens or something like that. But what I am excited about is just that people are trying to look at new things. We need better treatments. So I am happy that people are looking at alternative options because we need better treatments for depression, we need better treatments for PTSD, we need better treatments for anxiety, we need better treatment for pretty much everything. So there's that. Okay. Mood stabilizers. So this is for our bipolar disorders. People with bipolar disorders, meaning the manic phases and the depressive phases, don't really benefit from your classic antidepressants. Okay. An old mood stabilizer called lithium. Lithium is still one of the best drugs out there for treatment of mania and bipolar disorder. Now, lithium is a basic chemical element. Because it's a basic chemical element, you can't patent it. And if you can't patent it, there's no financial incentive. If there's no financial incentive, drug companies aren't interested. And if drug companies aren't interested, then drug companies will come up with new, trendier medications, even if lithium is still probably one of the best things out there. Now, lithium is not perfect. There have been a history of lithium poisonings. You need to have your blood monitored on a regular basis if you're using lithium. You also need to be aware of what your diet is, salt intake, things like that. If you are someone who can manage all that, lithium's great. If you're not, lithium's not a good option. There's a high rate of patient non-compliance with bipolar disorder in general. Lithium normalizes the mood, preventing both mania and depressed mood swings. The ultimate mechanism of action is actually unknown. Little effect in treating unipolar depression. Okay, so that is if somebody has just depression, lithium doesn't really work very well. Other mood stabilizers are actually anticonvulsant drugs. These are our valproic acid, our carbamazepine, and things like that. Okay. So if you want to look at this chart, this is, following the induction of antipsychotics, the number of patients in psychiatric hospitals has declined dramatically. Changes for psychiatrists. So psychiatrists used to do psychotherapy. And there are still some who do. However, now they barely ever do because you can charge a heck of a lot more for just giving out medications. And there's other reasons too. Priority and emphasis is really on establishing an appropriate drug regimen. And then psychologists, social workers, people with master's degrees in counseling end up doing the psychotherapy. Civil rights issues. Okay, so indefinite commitment to a hospital was deemed unconstitutional in 1975. Periodic review of a patient's status helps determine if the patient presents a danger to self or others. If the patient is not a danger to yourself, to themselves or somebody else, the patient is to be released from the hospital, and you cannot just keep them forever. Now, there are some concerns, right? So patients may have well-controlled symptoms while on medication in a hospital. Then when they leave, they may stop taking that medication and then be unsafe. Unmedicated patients tend not to be overly dangerous, but they may be too ill to take care of themselves, and then they often become homeless. That is a real problem. Okay. Also, our biggest place where we do mental health treatment for the severely mentally ill are in prisons. If you want to work with severely mentally ill people, go work in a prison. Our hospital settings, residential settings, just for people with mental illness are becoming fewer and fewer. Now, more mentally ill people are jailed each year than admitted to state hospitals. About 1/3 of all homeless people have some sort of serious mental illness. This is a problem that needs to be addressed in some way. Advocacy, lobbying, we need a lot more people to go into this area. So this is where we are. And often these mentally ill people are being picked up for petty crimes. We're not talking murders here. When something terrible does happen, of course, it gets so much publicity, and that is awful. But often these people are put in jail for stealing because they don't have any other way of getting what they need, and other little things like that. Okay. So I'm going to leave you with that. This is a difficult chapter for me to do because I have so much to say on each topic, and I know I need to pull it back. So I've given you a small amount on each area here. I've given you what you'll need for your exam, of course. And we will have a discussion question based on the alternative forms of helping people with mental illness. We'll say that, ketamine. And like I said, feel free to read more in your book. Maybe you've taken classes on these things before and this was all old news. Feel free to take a class in the future. Feel free to look stuff up online, and I will see you in the next chapter.